Everyone. I have just a couple housekeeping items to get us started with while everyone's getting logged in and settled. My name is Joni Napier, and I'm the program administrator with Mental Health America of Kentucky. And I want to thank all of you for joining us for today's webinar. This session is part of a statewide learning series designed to increase workforce capacity to address early serious mental illness and first episode psychosis. This virtual series is made possible by BSCA funds through the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. Today's session will be held from 3 to 5 p.m. Eastern Time, and your attendance will be tracked. Please make sure that your full name is being used as your display name in Zoom, and if it's not, you can click the 3 dots next to your square and click Rename to change that. Social work CEUs are being offered, and we are happy to assist attendees as needed to self-submit to other boards as well. Please note that certificates of attendance are only available to those who attended for 50 minutes of each instructional hour, and we also allow for 5 minutes of wiggle room in there because we know that life happens even during a webinar. As you have probably heard, this meeting is being recorded, and that recording will be shared via our YouTube channel. Please make sure that you are muted, and please put any questions that you may have in the chat, and we'll get those answered. Today's webinar is being led by Dr. Megan Sage. She is a doctor of social work with 15 years direct experience as a clinician, researcher, and leader in early psychosis intervention care, and she's been working with iHope team since 2016. She is the director and an assistant professor at the Early Assessment and Support Alliance Center for Excellence, OHSU-PSU School of Public Health in Portland, Oregon. And with that, I'm going to turn it over to her to get us started today.
Thank you so much.
Thank you.
Well, thank you everyone for being here today. I am going to talk today. Our focus today will be working with LGBTQ youth in early psychosis intervention care. And this webinar is being offered based on requests from folks on iHope teams about tips and strategies for working with this population. And as Joni mentioned, this is being recorded. So this will be available to your teams after the webinar today. We do have a couple of interactive breakout sessions. Since we're a smaller group, we may just talk through those together. And if folks are able to have their cameras on, that's great. If not, that's okay too. I know sometimes being on the screen can be challenging and people have different things going on, but thank you so much for being here today. So I will go ahead and share my screen. Share my slides, and we can get started. And feel free to ask questions throughout. And I'll just try to keep an eye on the chat, so if people have questions. So again, we're talking today about supporting LGBTQ youth in early psychosis intervention care. Again, my name is Megan Sage. I'm here in Portland, Oregon. I've been working in early psychosis intervention care since 2008. Had the pleasure of working with many folks throughout the years who've received services, those who've graduated from our programs, and working with several states nationally who are offering early psychosis intervention care. So I am a part of the Early Assessment and Support Alliance. I am the director. We are a part of the OHSU-PSU School of Public Health here in Oregon, and we get support from both of those universities as well as Oregon Health Authority to provide training and consultation, technical assistance for programs, again, here in Oregon as well as nationally. And I just wanted to take a moment to honor and thank the individuals who presented at our statewide learning collaborative here in Oregon a couple of years ago in October of 2022, as well as the OHSU Transgender Health Program and their perspectives. Those individuals' perspectives and knowledge have been integrated into the content of this webinar. And I'm also grateful for you all, for the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities, Mental Health America of Kentucky, and then our folks here in Oregon who support this type of initiative to be able to share this type of information with folks around the country. So just a little bit more about me. So I identify as a queer white female. I identify with my gender assigned at birth. I do not identify as a gender expansive individual, and I do not speak on behalf of the larger LGBTQ plus or gender expansive community. The information that I'm providing today really comes from research in the field of mental health and LGBTQ plus affirming healthcare. I think you all received information about the learning objectives today. I will go over those again, but this is really the presentation I'm doing today is really informed from research in this area of mental health support. So these are our objectives today. We're going to start out with just talking about the definitions of commonly used terms related to working with LGBTQ youth, and then go through some current statistics, information, as well as protective factors and risk factors for youth who identify as LGBTQ and those experiencing psychosis as well. There is some specific information about youth who identify as LGBTQ and the prevalence rates of psychosis and again, kind of the differentiation. We will go into mental health diagnostic categories, as well as exploring culturally humble care approaches and affirming approaches and practices with youth, as well as identifying any strengths or challenges that you all can identify in your current within your current team or within your current practices, and some next steps as far as resources or in ways to improve those practices within your team and your agency. And so, as I said, we are just going to start out with some definitions and hopefully to kind of help us all get on the same page around the language that will be used during today's webinar. Gender, sexual orientation, health, and mental health are all social constructs, culturally constructed categories. Gender and sex exist on a complex spectrum and are not binary. And so I've already used the acronym several times, LGBTQ. So that is defined as lesbian, gay, bisexual, transgender, and queer. The Q generally stands for queer. When LGBTQ organizations, leaders, and media use this acronym in settings offering support for youth, the Q can also stand for questioning. LGBT and LGBTQ plus are also used with the plus, which has been added in recognition of all non-straight, non-cisgender identities. And I do have several resources at the end of the slideshow that, as Joni mentioned, this PowerPoint will be shared with you all after the webinar. And again, the acronyms I've been using, those are acceptable acronyms to use: LGBTQ, LGBTQ plus. And again, there are some other versions of that as well. Sometimes you may hear LGBTQIA plus. In general, it's recommended to avoid the term gay community. That does not accurately reflect the diversity of different communities. Rather, the recommendation is to use LGBTQ community or LGBTQ plus community, and that is from GLAAD. And so when we talk about gender, we talk about different terms used. Transgender is the umbrella term. So non-binary genders such as gender fluid, gender queer, polygender, bigender, many others are genders that exist outside of that binary, the male, female, or man, woman binary. It's important to note that not all non-binary folks identify as trans, but many do share some of the same or many of the same experiences as trans folks. So you can kind of see how this is laid out as far as a larger umbrella term of transgender and then binary or non-binary. So when we're talking specifically about folks who are experiencing psychosis spectrum disorders, the research does show a higher prevalence of those diagnoses among BIPOC or Black, Indigenous, people of color, and sexual minority populations. So generally what the research has shown over time is that African Americans are 4 times more likely to be diagnosed with schizophrenia, psychosis in the United States, identified as having a schizophrenia spectrum disorder or having developed psychosis. and Latinx populations are 3 times as likely to receive a diagnosis of psychosis. And individuals who identify as lesbian, gay, or bisexual demonstrate higher rates of symptoms of psychosis. The emerging evidence in the mental health field links these disparities or these differences to minority stress, and that's related to bullying, discrimination, isolation, substance use, and social support. And individuals who identify as LGBTQ in the United States do face disproportionate discrimination and violence compared to the general population. 82% of individuals who identify as transgender have considered suicide, and 40% of transgender individuals have attempted suicide. LGBTQ plus youth are nearly 2.5 times more likely to consider suicide than their straight cisgender peers. Of course, there are many protective factors that impact how people are functioning, what types of experiences they're having, what types of symptoms they're having. Those protective factors include, but certainly are not limited to, family support, acceptance of one's sexual orientation and or their gender identity, safety and connection in school settings, particularly was noted in the research, as well as positive social supports and role models more generally, not just specific to school settings, but of course, family settings within their communities. And other protective factors were very much tied to and related to cultural and or religious beliefs and culturally competent care. And we'll talk later on today about culturally affirming care, what that looks like, and go through some specific examples. And as far as risk factors contributing to suicidality among LGBTQ plus individuals include, but are not limited to, discrimination, homophobia, violence, gender nonconformity, societal attitudes and supportive policies, family, religious persecution, and school communities that are not supportive, that are harmful for the individual. And so these are statistics from a couple of years ago. So in 2022, there were more than 220 laws that disproportionately targeted LGBTQ youth. They were introduced into state legislatures to restrict access to school, to sports within school settings, healthcare, books, inclusive curriculum, bathrooms, and none of these bills that were proposed, sorry, not laws, I misspoke. These were bills that were proposed. None of these bills were based actually in medical expertise or facts that supported how to support LGBTQ youth or how to treat LGBTQ youth. The evidence is growing that these types of bills are incredibly harmful, and especially in targeting of trans youth. And this, again, is information gathered by GLAAD. And I don't have the current statistics that are more recent over the last year or so. As I mentioned, these bills that were introduced were in 2022, but I know that bills continue to be introduced in states throughout the country and intending to restrict access for folks who identify as transgender. So one of the reasons that I was asked, or kind of what came out of behind me putting together this webinar to prepare and present to you all today, was just more information. Folks working in early psychosis intervention programs wanting some more information about diagnosis of specific to mental health disorders for individuals who identify as LGBTQ. Just to give some folks history who you may or may not have some of this history, homosexuality was first classified as a disorder in the first edition of the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, in 1952. This meant that people could be fired from their jobs, institutionalized against their will, denied mortgages, et cetera, other basic rights based on their identity as homosexual. That became a focus in the 1960s in the United States of the gay rights activism movements to remove homosexuality as a mental health disorder. It was considered an affliction that needed to be treated with various medical procedures. In 1972, Dr. John Fryer, who was a psychiatrist, attended the American Psychiatric Association conference, the APA conference, and talked with folks, and actually came out himself as a person who identified as homosexual. And that what happened at that conference actually helped lead to the removal of homosexuality. It was based on years of activism, but him showing up and talking about his own identity at the conference helped move that forward to where homosexuality was removed from the DSM and was no longer classified as a mental health disorder in 1973. However, it was replaced with the term sexual orientation disturbance. If an individual was, and it was described as an individual who was disturbed by or in conflict with or wished to change their sexual orientation. In 2019, the World Health Organization, who officially no longer categorized being transgender as a mental health disorder, and the newly revised version of the ICD-11, the International Classification of Diseases, reframes gender identity disorders as gender incongruence. So that definition of gender incongruence is characterized by marked and persistent incongruence between an individual's experienced gender and the assigned sex. Gender variant behavior and preferences alone are not a basis for assigning the diagnosis in this group. And gender nonconformity is now included in a chapter on sexual health rather than being listed as a mental disorder, and that was the case previously. So this is the mental health diagnosis criteria for gender dysphoria from the current DSM-5, which was actually published several years ago, over 10 years ago now, but that is the current DSM that we all use to do our diagnoses within the mental health field primarily. The ICD is used more internationally. So the definition, as far as someone meeting criteria for gender dysphoria, would be a marked incongruence between their experienced or expressed gender and natal gender of at least 6 months in duration. And then, as is the case in the DSM-5, it needs to have manifestations in a number of different ways. And then also on the next slide, I'll talk through also cause distress or difficulty in functioning. So at least 2 of the following need to be present: a marked incongruence between their experience and expressed gender and their primary or secondary sex characteristics, a strong desire to be rid of one's primary and or secondary sex characteristics because of that incongruence with their experienced or expressed gender. And again, you can see in parentheses that in younger adolescents, they may be what is anticipated as far as developmentally as the sex characteristics that are anticipated to be developed. And then kind of moving along here, this strong desire for the primary and or secondary sex characteristics of the other gender, a strong desire to be of the other gender, or an alternative gender that is different from their designated gender, a strong desire to be treated as the other gender, and a strong conviction that one has the typical feelings and reactions of the other gender. And again, back to what I mentioned earlier, of course, when we're looking at mental health diagnoses, mental health disorders, what we're really kind of looking for in terms of actually being able to make that diagnosis for folks to meet the criteria is if they are experiencing clinically significant distress or impairment related to functioning, so related to social, occupational, other areas of functioning. So if this exists with a disorder of sex development, or the condition is post-transitional, that is, they've already transitioned, or they've undergone at least one sex-related medical procedure. So again, when we're thinking through, we have folks coming into our programs who may be exploring their identity, their gender identity, and exploring, feeling like things are coming up for them that are related to their gender, that are causing them distress, that are causing them impairment. that is clinically significant, then that would be a time of possibly looking to see if this individual would meet criteria for gender dysphoria. And again, what we'll talk about later on in this webinar today is really ways to support folks who are questioning their gender, or are wanting to transition, and feeling that is very clear for them, or maybe not clear for them, ways to support them in our programs when we're working with them. And generally, I would say, working in early psychosis intervention, we wouldn't necessarily be giving folks a diagnosis of this diagnosis of gender dysphoria. That would really be up to folks who specialize in this type of diagnosis and treatment. But there are lots and lots of ways you all can support folks in your program who these different areas may be coming up for them, where they need additional support, they need advocacy, they need to have care that is responsive to what is going on for them and where they're needing help. And so that's really the intent behind presenting this information to you all, not necessarily, again, kind of within the scope of programs where they would be potentially giving a diagnosis of gender dysphoria to folks. But certainly partnering with other professionals, medical professionals, with other folks who could potentially give that diagnosis, and you all could coordinate and work together to support the young person and their family members and supports. Any questions about that before we move into kind of some more specific information about culturally responsive care? Okay. So what is the definition of culturally responsive affirming care in mental health? It's the intentional, consistent decisions that mental health care providers make to see, to respect, to celebrate the aspects that make each person unique. It's really, culturally responsive care is really about acknowledging each person's intersectional existence in the world, and how that existence, how they see the world, how they feel they fit into the world, shapes their experiences. And so that's what we really want to kind of work together in our teams around, what that looks like for your programs, what that looks like for the individuals you serve. According to the AAMC, the Association of American Medical Colleges, gender-affirming care encompasses a range of social, psychological, behavioral, and medical interventions that are designed to support and affirm an individual's gender identity when it conflicts with the gender they were assigned at birth. And gender-affirming interventions help transgender people align various aspects of their lives with their gender identity. That identity can run anywhere along a continuum that includes man, woman, a combination of those, neither of those, and fluid. And so gender affirming care really can range from counseling to changes in social expression to medications such as hormone therapy. But again, kind of for the purposes of today, of this webinar for you all working in early psychosis intervention care, it's really about providing that support for folks to explore their identity, to feel that they can can be congruent with their experiences, and that's additional support for potentially family members, other supports, it could be school staff, to really help them support the youth. Especially for children, the timing of the interventions that are gender affirming is really based on a lot of different factors. Of course, parental consent would be part of that for those who are younger, surgery, and any kind of, medical surgery is rarely provided to folks who are under 18. It's really more about listening, building that environment where they can explore their emotions, they can ask questions, they can explore their concerns. That's really kind of the goal, or what's really encompassing as far as gender affirming care is listening, building understanding, answering questions, helping advocate or connect folks to services and supports that are really specific to, in this type of specialized field that's a part of the larger mental health field, but it certainly has its own kind of experts and research behind what is best to support this population. But I did want to bring in information about several different practices that you all can employ and utilize within your programs to support LGBTQ youth. That includes, first and foremost, us each exploring our own implicit bias, examining and exploring our own biases that we all have. And, that could mean, inadvertently kind of making assumptions about sexual practices, avoiding asking people questions about their identity, generalizing based on their identity, such as race or gender, kind of generalizing their narrative, persisting with an intervention without considering whether it aligns with their customs, their preferences, or their practices. I was speaking with a young person. It's been probably a couple of years now. It was actually part of a fidelity review I was doing for a site. And the young person described to me that they had an incident where they had been interviewed. Someone was doing a mental health provider was doing an assessment with them, asking some questions about past trauma. And they had mentioned that they had been sexually assaulted. And when the interviewer went back and kind of rephrased the question, they used the term rape, with which the young person said that is not what I said, and that's actually not the same thing, and that was very hard for the young person to have had that experience where their language was taken and interpreted in a way that wasn't accurate. So it's really, that was the interviewer making an assumption instead of considering, using the young person's own language and really considering and centering what they were speaking to, what was their own experience. So that's just an example of really just for all of us kind of reminding ourselves to really be really intentional and deliberate about ensuring we're using a young person's own language when they're speaking to us about their experiences, about how they identify, about what's important to them, and really bringing that into our care with them as we work with them. There is a free online implicit bias test that Harvard, they've had that online for several years now. If people are interested, it can be helpful. Again, just we all have implicit bias, and to just kind of get a sense, do that brief online test to just get a sense of maybe areas you want to do more of your own research or just work on for yourself as a practitioner. Another area of gender affirming care or culturally affirming care, which encompasses gender affirming care, would be to just, again, work on kind of exploring cross-cultural communication, your own skills in the areas to really be able to have conversations with folks about intersectionality, about their beliefs, about their practices and perspectives, and centering that in your work with them. The cultural formulation interview, the CFI from the DSM-5, which is a part of the DSM-5, I put the link here. That is a great tool that can really help kind of guide those discussions with folks about their life, what's important to them, how maybe culture or religion, their family beliefs, other influences have shaped them or do shape them. It's a great tool that anyone on the team can use. It's not just for therapists or clinicians. It's a way to, again, explore areas that are meaningful to them. And there's also a part of the CFI that is exploring past experiences with healthcare providers, mental health care providers, with systems in general. And again, going through questions from the CFI or using the entire cultural formulation interview as part of your assessment process, or maybe a little bit further on once someone has become a part of, in treatment with the team, where you can really get at that exploration and kind of, again, find out what's important to people, what are their values, what is their previous experience, where maybe they have experienced discrimination in certain settings, whether it's school or healthcare settings, that can really impact kind of how they're experiencing receiving mental health treatment or receiving healthcare treatment, or could be potentially looking at ways to address barriers to someone wanting to receive medical intervention if they are wanting to medically transition. So again, all of these experiences we know shape who we are, each of us. So it's really important to use a tool like the CFI, or there's other tools as well, to really explore what's important to folks, what they want to focus on, how they identify, and to integrate that into your care with them. It also includes actively engaging in practices that acknowledge those power imbalances that exist. You all are, part of mental health agencies, community mental health agencies. You're working with folks, direct care, and there are those power imbalances. We make decisions about who does or does not meet criteria for IHOPE programs. We make decisions about, transitioning folks out and what that looks like. So we really want to try to partner as much as possible, acknowledge those power imbalances, and then really partner with young people and their family members and supports, so that the environment is supportive, so that we're centering their experience and what is important to them, and to help advocate for them as needed. And this slide is more focused also on family members and supports, and how to kind of encourage those culturally responsive, affirming practices with them. And again, this is an area that came up in my consultation with some of the IHOPE teams more recently, around how to respond to family members or support systems who may not understand, why their young person or how they're identifying, or, may have their own beliefs about gender identity or someone who identifies as LGBTQ. So these are some different ways that you all can support family members and support systems by recognizing and responding to their uncertainty, their grief, maybe they don't have information, maybe they don't understand, maybe they don't have access to resources, and they're responding to their own well-being as well, so that doesn't significantly impact or negatively impact their relationship with their young person who's in care with us as part of IHOPE. So helping those family members and support systems address their own feelings and also get their own resources and information, their own supports, so that they can support their young person. So that could also be using the CFI with family members and supports, again, to understand their beliefs, their values, and their perspectives. Again, so that they can get their own supports, kind of outside of having the young person have to answer those questions or kind of be their educators. We would really encourage family members and supports to get access to their own resources and supports. Addressing any misconceptions, any lack of information. We all come in with our own beliefs, our own information, our own knowledge, and we want to address any misconceptions or lack of information. Again, help them get the information themselves, and really acting as an advocate for the young person. If the participant does give permission, and if the young person or the participant is comfortable, certainly you could help facilitate discussions with family members and supports, and talk to them about ways they can be supportive of their young person and really be involved in their mental health treatment. And certainly that is a very large component of early psychosis intervention care, is that family member and support involvement. Research shows that is, one of the most important areas for us to work on in early psychosis intervention, is helping to support the young person to have that connection, that positive relationship with their family members. And that is really, when we look at long-term outcomes for folks in early psychosis intervention care, that's one of the major components of those kind of facilitating those long-term positive outcomes, both clinical and functional outcomes, is having that family support. So that is a large part of our role, is to help kind of navigate with folks. What kind of support does the participant want? How much do they want their family involved? If they don't want their family involved at all, exploring that with them over time while they're in our program to see maybe it's not mom involved, but maybe it's a pastor, or maybe it's a coach, maybe it's a significant other or an aunt. So again, there's lots of possibilities. Really, the goal is to have these folks in our care have that social support around them and continue that social support after their time with us, again, to positively impact those long-term outcomes. All right. So I know we kind of have a smaller group, so I'm wondering if maybe we can just do kind of a more small group discussion. And Joni, you had the I did a short kind of a write-up that actually from our transgender health presentation a couple of years ago. Those folks put together kind of a scenario. So I was hoping we could just look at that, and we can look at it together and then talk through, there's a few just different prompt questions if people are open to doing that. Looks like I can stop sharing. Oh, thank you, Joni. Joni put it in chat. The link to the Google Drive that has the scenario. So people can open that and access that. And there are a few questions, but I can give folks time to read it. So maybe we'll just take a few minutes and folks can read that, and then we can just have kind of a discussion about what you think about ways you would support this young person. And we can also, have folks put things in chat too. So we can plan maybe to come back together at, let's see, 12:45 Pacific. So that's 3:45 for you all. And then we'll talk about the young person in the case scenario. All right. Have people had a chance to read the scenario?
Yes.
Thanks, Allison. All right, great. So Ashley, and I know. So it would be helpful to just kind of get a sense if folks are able to share a little bit about kind of what they think about the first question, which is at the end there of the scenario of what of the practices that we just talked about would you utilize if you were working with this young person in your program, how to support them, where would you start? What approaches would you take? Anyone want to share? You can also share in chat.
Hi, Megan. This is Allison. I was just going to share that I think that given all the family issues going on and the young person feeling kind of unheard, I think one of the first steps I would do is just kind of listen, hear them out, respect some of their preferences, their name, those kinds of things, just to show some respect and care during the session or during the interaction. So I think just really being open and listening would be a good first step.
Absolutely. Yeah. Thank you so much. Yeah. Yeah, I think that first step, like you're mentioning, of just feeling like listening to them, and so that they feel that he feels heard, because a lot of the experiences, you know, with home have been not supportive or positive. And again, this kind of scenario was designed by folks with lived experience, with personal experience. And I know, again, that has come up in some of my consultations with folks in IHOPE teams where the family members just kind of don't have an understanding and just aren't supporting. So they're using the person's dead name. They're using not using the pronouns that the person prefers, that they identify with. So those are, yes, exactly, very good, like just kind of first steps, establishing that care and you know, showing them that you're listening as their counselor or provider. Other ideas about what you would do, creating a safe space, Nelson? Yeah, thank you. How and let's see, Ashley put Ollie being 18, going to the doctor. Yeah, absolutely. That, and I think that's one of the things that you know, again, comes up is if someone does want to, you know, seek kind of more specialty medical care, maybe potentially talk about transitioning and the family is unsupportive, the person still lives at home, but they are 18, they are of age where they could get that care. What would you think about as far as kind of what that safe space would look like? Nelson, do you have other things you want to share about like what that could look like for what a safe space would be? Or anyone else, not to put you on the spot, Nelson, but others.
Yeah, I think it goes right along with what Miss Allison shared earlier, and it's just, you know, it appears that Ollie hasn't really established an opportunity to just vent and be real and you know, just say what's truly on their mind without having that fear of rejection, fear of, you know, critiques and all the negativity surrounding it. So just establishing a place where, you know, he knows, Ali knows they've got a place to go to where they can be themselves and say whatever it is that they're truly thinking and feeling and be heard and be supported.
Yeah, great. Thank you so much. Exactly. Yeah. That safe space where you have that, you know, a security established that you're not going to be sharing things with their parents that they don't want shared, or, yeah. Certainly that kind of goes into the next question though, just around risk factors. Some of the things that were in the scenario around thoughts about suicide. So what approaches would folks take to kind of do a bit of an assessment to see where maybe more support was needed as far as risk with Ollie?
I think this is Allison. I think it might be, you know, kind of just going in the flow. I think it would be helpful to validate, you know, what he's feeling, you know, that hopelessness and those thoughts of wanting to take too many pills and things. And, you know, sometimes there's some people you can jump right in and say, oh, are you having, you know, suicidal thoughts? But sometimes you can take a little bit softer approach before you actually ask the question. And so I think before, you know, jumping to are you suicidal, to just kind of like take his statements for what they are and just explore them.
Yeah, absolutely. Great. Yeah. And again, kind of have the, like you're saying, have the assessment be really grounded in, of course, like that engagement, that you're listening to him, you're there, you're hearing him. It is a space where he can vent and just share what's going on. And also keeping in mind, you know, those phrases that he's mentioned that indicate that there may be something else that needs, you know, more attention as you get more information. What did you all see kind of as the strengths or the resiliencies there for Ollie, the assets that you would draw on working with him?
I'm going to give him some time to write some stuff in the chat. See what we get.
Yeah, sounds good. You can take a couple minutes. Self-awareness. Yep. Great. Yeah. Thank you, Nelson. Definitely has some insight, yeah. Others, you can type in chat or you can unmute. Lauren wrote acceptance from some friends and teachers, support at school. 2 teachers that support him, adult support, right? And there was also a mention of an aunt, right? He had some family that was supportive too, aunt and cousin. What would you all think about engaging them or talking to Ollie about engaging them as well?
I would say it's important to assume that, like, not to assume that because he has a close relationship with some of these people that there would be an actual support. So I think exploring what those relationships are like, and if they are actually helpful, or kind of figuring out where the helpful points in that relationship may be.
Wonderful, yes. And that definitely, again, that came through in our kind of statewide learning collaborative, folks who identified as transgender said, like, exactly what you're saying, Allison, don't assume, like, even if we see someone as a support or we speak about that we necessarily feel safe bringing that person in. Like, it's a part of the conversation. It's a part of like what is going to be most helpful to us as individuals, and not just automatically trying to kind of, go bring a parent in or bring someone else in without really having that full conversation and ensuring that that is a resource that they want to connect with, even though we do know that those resources and supports are so important for the people that we work with. We really want to be cautious and just thoughtful and planful, and really centering what they're saying is going to be a fit for them, rather than just kind of just jumping to those places, exactly like you're speaking to, Allison. It states he values his friendships, loyal, kind, thoughts about the future. Kind of making plans, whether that's related to his identity or other things. There's lots to explore. It sounds like he's been a good student in the past. Other things coming up for folks when you think about strengths. Done a lot of research, right? Like, it sounds like he's done his own research about transitioning and what that could look like, and if that's something he's interested in. And I think, to your point, Nelson, he knows himself. Like, he says, I'm an introvert, kind of, I know what I need. I know when I've kind of hit too much socially. Sounds frustrated with how to get to where he wants to go. Yeah, exactly. And that's kind of to the next question is, and you mentioned, Ashley, in the chat, if that is something Ollie is wanting to pursue, if he is wanting to pursue gender affirming care, specific to transition, other areas, would you, again, I know this is all role play hypothetical, but who would you involve, or how would kind of you start to have that conversation with him to see where he wants to go? Because it does sound like he's unsure. And that could mean bringing in other resources too. But yeah, what do folks think about that kind of discussion question 4? Would you involve the parents? How would you approach that?
I don't know. That's a tough one, but I think I'm not sure this is correct or not, but I think I'd let him determine the level of involvement and who he wants involved in those types of decisions, because they're life-changing, life-altering, very important decisions at this point. So I'd let him take the lead role when it comes to that. Of course, maybe aiding a little bit in discussing pros and cons and possible outcomes of different decisions made. But that's how I think I'd look at it.
Great. Yeah. Again, kind of following his lead to what feels safe, what feels supportive. Asking him, yeah, great, Ashley, asking him who he's comfortable bringing into treatment, how he would feel about family sessions. Again, is it that folks need kind of that education about pronouns, about dead names, or is it, is there something else there? We really don't know. There's not really specific information about that. So potentially asking if he did want to have an aunt or cousin join, how he would feel about you in your role doing a little bit of advocacy, bringing in the parents, and just, yeah, following the lead on kind of where to go from what information you get from him. Yeah. There's another, if he'd like to try with his parents joining, getting them to understand, seeing if they would be willing to come in to get more information and understanding. Yeah. Great. Yeah, exactly. I mean, it really is about just, just as we've talked about, starting with where they are. And then, as people mentioned, he has a lot of insight. He has a lot of, it sounds like he's thought through kind of where he wants to go, but just feels stuck in how to get there, and what he needs to get there. At what point would people kind of, as the providers, when would you try to find other resources that are maybe more specific to transgender youth? What would that look like for you all, kind of, again, in the areas where you live and work? What resources would be available? Do folks have familiarity in your areas of places where you could get information, or folks could get specific care related to transgender care for folks, whether it's not necessarily transitioning, but just more specialized resources?
I know in Lexington, we have Lexington Pride Center, and there's always Trevor Project as well, which I know is national.
Yeah, great. Yeah. Yeah, there's a lot of national resources that can be really helpful. I mean, obviously not for someone's like specifically for medical care, but definitely there's a lot of resources out there that, I know when I've worked directly with folks, they can, we kind of do a Google search together and see, what information they feel is useful, and, potentially even joining, an online support group or just chat, just different ways to make those connections. And Ashley was saying we did not have more specialized care and resources. Lexington is the closest, but online options. Yeah, right. Yeah, support groups and online options. So I think that's part of it too. And again, that's been part of the discussion, is just if people even feel comfortable kind of accessing those resources, or feel like that's something that they can do or are able to do. And the fear that can come along with actually kind of taking that step to pursue that is something to be very aware of. And I think you all have spoken to it really eloquently, of not stepping ahead, not kind of pushing someone one direction or another, because we really want to take it at their pace and ensure that we're not inadvertently putting someone in a situation that is at risk, or that will cause, increase in symptoms of suicidality or depression, with the best intent of like supporting them, but not getting ahead of ourselves, and really following their pace. Yeah. Taking their lead. Great, Lauren, collaborate with your direct and clinical supervisor, seek how to get trained in writing gender affirming care letters. Yeah, that's great. Yes, I know there are some resources for that, and I can put that in the PowerPoint to send to you all as well. We are, as I mentioned, we have a transgender health clinic through OHSU, and they do a lot of that type of work. And so we're starting to partner with them more and more. And so I know that they have some resources as well. Yeah. Great, Joni. So you said a different kind of resource. You kept a running list of local employers who are accepting and affirming of trans employees. That's great. That's a great resource. Yeah. Is that what area is that for in Kentucky? Is
That was in Lexington.
it was in Lexington? Okay, yeah.
Mhm.
Yeah, I mean, I think that would be great. Any resources like that to share with the teams, even if they're not, not they're spread throughout Kentucky, but just to be able to get an idea of what those resources look like. So that was kind of the remaining part of yeah, before I move on though, any other questions or comments about this about the scenario, or just kind of what people have shared? And we do know using a trans youth authentic name and pronouns helps their, improves their mental health. It reduces suicidal ideation. So even just being able to kind of get to a place and working with families around using their authentic name, using their pronouns can really can make a difference in that type of affirmation around what will be most supportive for them. I'm hoping that people can maybe share what do you feel is a strength in your program or the place you work in providing care for youth or for individuals who identify as LGBTQ. One area of strength for each of you. If anyone wants to share, you can put it in the chat or unmute.
So this is Allison, as the program administrator for first episode Psychosis at the Division of Mental Health, we don't provide direct care. We provide macro level social work, overseeing funding and grants and, really working closely with the community mental health centers. But I will say that one of the things that happens up there that's also kind of translates down to the community mental health centers is a constant conversation and knowledge quest to try and do this right. So I really appreciate when people can be very honest to say, I'm not sure how pronouns work. I don't understand all the difference in the languages and things like that. And so just being willing to continue to have that conversation, to continue offering trainings, to continue just really being vulnerable about it is really, really helpful.
Great. Thank you so much, Allison. Sorry, did I interrupt someone? Someone else want to share what's a strength about where you work or your team specifically in supporting LGBTQ youth?
I will say that for Mental Health America of Kentucky, again, we work in more of an education and advocacy role. So similarly to Allison, we don't always work directly with youth. But I do feel as though our executive director, Marcy, leads us in utilizing as many resources as possible and learning from as many people in our community as we can. And I think that that's really important.
Thank you so much. Yeah. And what about what is an area of challenge? Like what additional support or resources, trainings may be helpful specific to care for LGBTQ youth?
In listening to our iHope teams share information, I think that some of what they see out there is, we've got some pretty rural areas in the state. And so those areas tend to lack a sense of community. So they may not have other people in the LGBTQ plus, community to connect with. They may not feel comfortable talking about it where they're at. So I think that that's one thing. And then I think that, again, that geography limits too, that if they wanted to, it limits them getting access to it. I think that a lot of the virtual activities has probably helped some of that, but if you think about geographically, also, you know, some parts of Eastern Kentucky, they struggle to get signal. So there's just some, you know, some people out there that I feel like might be pretty isolated or really have some troubles connecting with other people.
Yes, absolutely. Yep. Yeah, absolutely. And I think that's where the online can be helpful, but also, yeah, there are other barriers too. And if people don't have access, they don't have reliable internet, or they don't even have access to a laptop, or kind of that's restricted in their home or something. Yeah.
We have a lot of that in our area. I work in community health based out of southeastern Kentucky.
Mhm.
So we have a lot of issues with even finding employment for them. Like I have one client right now, and they are non-binary. And typically, you know, before they go and they get hired on at places, they'll let them know, hey, this is my preferred name. This is my pronouns I would like to be called. Is that okay? They'll check because it's not widely accepted. And right now they're stuck in a position that they feel like they can't get out of. And they said their actual employer is purposely calling them their dead name and using she, her pronouns purposefully, you know, and they absolutely hate it, you know, which we've got our supportive employment and myself and them all looking for something else for them at this moment. But I mean, the jobs are few and far between, and even if they can find it, finding acceptance. I mean, I think if it was just somebody in the community who did not know their pronouns, that accidentally used the wrong pronoun with them, I don't think it would bother them as much as the employer knowing that they prefer to be called this name and that they prefer to go by these pronouns, and then purposely over and over again, no matter how many times you tell them. So we run into that a lot here. So there's not a whole lot of support other than online, and then you run into the problems of they don't have a computer, their phone minutes ran out, like different things. It's hard to have those connections.
Yeah, those are great examples, Ashley. Thank you. I'm just curious, again, you know, every situation is different, but would the young person be open to the support employment person talking to the employer about the pronouns? I mean, is that a conversation that's happened, or?
I'm going to work on that. Roxy's been off on vacation, and she's our lead, so she'd be the one to really reach out and try to talk to the supportive employment about, hey, this is one of our people, this is what's going on. So she'll be back tomorrow, and that's the first thing I was going to talk to her about, was reaching out to them and kind of seeing if they could gather a list in the area maybe of companies that would respect their pronouns in their name.
That are affirming, right? Yeah. Yeah. And of course, you know, the participants' permission to do that. But sometimes I think it's like that education needs to happen, and then, you know, people can get on board, and sometimes that's not the issue. So it's hard to know, yeah, what the reason is that the employer continues to use their dead name and the incorrect pronouns. Yeah. But that's a great example. Do you all have access, like, you know, with phone minutes running out, or would you have access to like funds where you could, you know, purchase additional minutes, or purchase like a plan so that someone could have access to support?
We do. Right now, though, the end of June, that's been kind of a struggle getting things approved and accepted. And I think a lot of people's waiting on July to hit. So with it being the end of the fiscal year.
End of the fiscal year, yeah. Do you, not to put you on the spot, Allison, but are there kind of funds that could be used through the state funding to kind of support this type of, if people need additional resources to get that type of support?
Sure. I know through the iHope program, if they are an iHope consumer, then yes, they can use some of the funds that they've received to buy anything that, you know, would help promote, you know, services, engagement, you know, that could be part of their treatment plan. They're allowed to purchase those kinds of things. And I'm sure that there's probably other programs within the community mental health centers that also provide support or items to individuals who are struggling. I mean, I know that you can, if they don't have a cell phone, they have that cell phone plan, I think maybe through Medicaid or partnership with Medicaid or something like that. So there are some ways. I think one of the barriers is just knowing that that's a barrier, because, not everybody's going to, that's also a cultural thing. Don't ask for help. Don't let them know we're struggling. And so there's, some mistrust of the systems, but, I think identifying what they are struggling with, and then asking them what they're comfortable, what type of help are they comfortable with? Do they want the help? And then trying to go from there with seeking out the best resources.
Yeah, absolutely. And coming back to, any of our consultations or, directly like working with Allison and myself around if those things are coming up and if there are ways we can help problem solve or provide additional resources. And again, I know, very much culturally here in Portland, Oregon is different than places in Kentucky and across the country. And certainly there are parts of our state here where, certain things aren't talked about or brought forward. There aren't resources. So I am, just want to acknowledge, very aware that this can be challenging to really be able to feel like you can really fully support LGBTQ youth just based on a number of different factors. And that's where, again, bringing in questions from the cultural formulation interview, or just kind of trying to find out people's experiences and how they orient. Maybe they have had negative experiences with systems in the past, or just different kind of barriers, and how to support working through those kind of on the local level as well as more on the macro level. Any other comments or questions? Kind of that's all I had as far as content, but I'm happy, if people want to have more of a discussion, if people have questions, there's no wrong question. If in any way I can be helpful in answering things or facilitating getting additional information for folks.
Where would you, so after today's webinar, and people, are still trying to maneuver and build in new language into their own interactions, and maybe doing some changes as far as how they interact with other people, what are some good resources for people to reference? So I know that a lot of times people want to know what is binary, non-binary mean, and how does that relate? How does gender, sex, all that stuff relate to each other? And so what is the best resource to go for terms and explanations? Do you have any recommendations for that?
Yeah, absolutely. I will put that in it's at the end of the PowerPoint, but there's a great glossary of terms. The Trevor Project is a great resource, but there's a couple of other ones as well that really just outline pretty well, I think, the different terms, and kind of go through some of them are very, very specific terms I had never even heard of. So I can definitely make sure that you all have those references in the resources slide. And then I also have some just around like affirmative counseling with LGBTQ folks. There is the National LGBTQIA plus Health Education Center they have a great glossary. So there's a lot of good resources out there. Yeah, good question.
Awesome. Thank you so much. Now, what about, I've got a couple questions.
Yeah.
So what about if you're working with someone and you don't particularly support some parts of their identity? Do you have any thoughts on how, people can work through that, or how to handle it if they find themselves in that situation.
Yeah, good question. I think one of, that resource around just kind of looking at your own, your own orientation, like your own identity, how your own biases, which again, we all have, that implicit bias test through Harvard can be kind of a nice way to, like, again, just kind of think through, like if something's coming up for you in your work with someone, because it's your own, personal belief system, which is very valid and very important. We all have our own belief systems and kind of the way we were raised, the way that we think about things, whether it's religion, culture, spirituality, identity. So I think just starting with kind of examining where that may be coming up for us in our work with someone, and really having a space, whether it's in supervision, certainly in consultation with me, kind of being able to explore some of that if people are willing to kind of share. I know it takes some vulnerability to kind of be able to share, like, this is coming up for me. I'm having a hard time kind of knowing how to work with this person because I just, we have different beliefs and different orientations, and it doesn't make sense to me, or I don't know how to work with them. I don't know how to approach this situation. So really getting that supervision and support. I know, working with folks over the years personally, where some of their symptoms of psychosis were really rooted in religion. And that is not, a personal kind of attribute for myself, where I identify as being religious. So I always would have to, that's just one example of many, but always have to kind of be able to take a step back and ensure that I was not letting my own bias get in the way of really being able to support the person in what they were bringing. So I think it is just like an ongoing, first it's right, just having that awareness and insight, and then getting some support for it yourself if you need that, whether it's in individual supervision, group supervision. It's also a great idea, I think, for teams, if they can, to kind of do once in a while, or whether it's monthly or less often, quarterly. We have our statewide meetings for iHope, where we're kind of talking about some of these things together and bringing in resources and sharing, and people really being able to share their own experiences and what's worked and what's been a struggle, and how they've kind of addressed those challenges in their work. I think some of it is just the dialogue, having the dialogue.
Yeah, thank you.
Mm-hmm. Yeah. Other questions? Resource needs that folks have?
I have a few more, but I was just giving other people a chance to ask some curious questions. Megan's a great resource, so if anybody has anything, now is a good time to ask and pick Megan's brain.
I'm recording still right now, but do you all want me to go ahead and pause the recording or stop it so that folks can ask questions and not be recorded? People might feel a bit more comfortable.
Yeah, I think that makes sense, if that's okay.
Okay.
Yeah,
Okay, yeah,
yeah.
absolutely. I'm gonna go ahead and stop this.